when I was a young student in the 1970s, the treatment for acute heart attack was nothing. And I recall vividly making rounds at Duke University with the great Eugene Stead, and a patient with a big heart attack had come in the night before. And as students standing around the bedside, watching a patient still in pain, still in heart failure, and asking Dr. Stead, well, what do we do now, Dr. Stead? He says, do nothing. Where's the next patient? The barrier just is clinical outcomes. We just try everything, and we never quite see anything to get past that barrier. And that barrier still remains about a 3% mortality. A rehospitalization rate that's actually pretty high, could be anywhere from, I've seen as high as 15 or 20%. I think there is some complacency. I also think that anecdotal assessment of how you're doing is not very good. And I would cite an interesting response I heard from some doctors when we talked a little bit about this. And their response was, well, all of my patients recover their LV function. What do I need this for? And the reality is that couldn't be further from the truth. The real percentage of patients who really do recover completely is pretty small. It's probably 10 to 15%. There are a couple papers that have recovery about 20%, but you got to be a little careful, because the ones that really recover like that, they don't start with 30% ejection fractions. They're starting with 50%, very short door to balloon time. They've already made it past that first barrier, so they're going to recover. But that's not what we see in SSO2. SSO2, we see bad ventricles in the 30 to 40% range recovering completely to ejection fractions of 60%. And that's strikingly rare. And with SSO2, what we're seeing as a challenge is that the doctors have a little trouble with interpreting infarct size, because that's relatively new. Years ago, we just had technetium or nuclear assessment, which nobody really believed is accurate. But MRI is so exquisite now, and you can tell with great certainty if there's improvement. And the improvement that we're seeing in infarct size with SSO2 is actually as good or better than the improvement that we saw going from lytics to stents, which is a pretty impressive number, 5 to 8% improvement, or absolute but relative 20 to 30% improvement in infarct size. The patients that I've followed personally, you can see a direct correlation with the reduction in infarct size and the recovery of LV function. And as I said before, you do expect some spontaneous recovery, but not to almost normal or even hyperdynamic. So by driving oxygen down that gradient, you get cellular effects, I think, that are salutary, that are going to make the heart recover quicker. Number one. Number two, SSO2 seems to improve capillary flow, totally separate. There's a hydraulic effect that it has. And that's very important, because the more blood flow you get to the tissue, the more oxygen you get to the tissue. Then finally, the endothelial cells seem to be damaged quite a bit during an infarction. No surprise, we've known that for a long time. And the endothelial cells seem to recover a lot quicker when they're fed a high dose of oxygen. One of the more interesting patients we had was a fellow who presented within 2 to 3 hours of his infarction, and he got to us pretty quickly. He was stable, but he was having significant chest pain and ST elevation in the emergency room. He received heparin and aspirin and the usual approach down there, and was taken to the lab very quickly. We took our pictures right away. He had a totally occluded LAD. De novo, by the way, no warning whatsoever. And big infarct by LV gram, probably 35% ejection fraction. And the case went very smoothly. Access went very quickly, and we got a great result. His chest pain went away. Angiogram looked great. He had TIMI-3 flow. And then as he was recovering, he remained symptom-free, as he does today. It's 5 years later, and he's still asymptomatic. And he's had a really uneventful hospital course. His LV function recovered completely, not just better, but his ejection fraction is completely normal. You can't even tell that he had an infarct. SSO2 should absolutely be standard of care for all big infarcts. What you have to convince the doctor to do something they usually don't do, which is check LV function right away. So typically, a STEMI will come in and doctors will open up the LED, and nobody does LV grams anymore, nobody does echoes on the spot. They'll get an echo a day later, but they're not going to do it right away. So it should be standard of care. If you have any big infarct with a pretty big wall motion abnormality with a lot of muscle at risk, it should be standard of care.